Okay, guys, thanks for coming. And to the online community, thanks for joining us. On behalf of Captain Scott Goldstein, welcome to the Pikesville Volunteer Fire Department training space. For those who I haven't met, I'm Sean Barinholtz. I am adult anesthesia and critical care physician at Hopkins. I'm a member here at Pikesville, and I have the honor of serving in the medical director's offices, CAR 609. On behalf of the medical director's office and Andy Pollack, welcome. On behalf of the EMS staff, leadership who's also been exceedingly supportive, Director Schenning, Captain Willits, and Captain Stewart, who I think will be joining us tonight. We thank you. We thank you for what you do. We thank you for your dedication for lifelong learning. A big shout out to Akiva for running our live stream. Thank you so much for sitting in. Super appreciate it. Tonight we have Ellen Lemkin talking about respiratory emergencies. Dr. Lemkin is an emergency medicine attending at Hopkins Bayview Medical Center. She was a clinical pharmacist and an EMTB before starting medical school. She graduated from the University of Maryland, completed a residency at University of Maryland in Emergency Medicine. She currently serves as the base station medical director at Bayview and teaches residents, physician assistants, and medical students. Ellen, thank you so much for being so crazy generous and being here.
Me? Oh, thank you. Okay.
Thank you.
Great. Okay, well, this is great. So so glad to see all you guys. This is very nice. I'm going to go through respiratory emergencies today. We can edit this as much as you guys like. So if you want me to cover anything in particular, if there's anything we want to go over in more detail, less detail, please just let me know. So we can tailor it to what you folks want, okay? So the first thing I'm going to go over is an overview of assessment of the respiratory system. We're going to then talk a little bit about differentials when we have respiratory emergencies. In a case-based format, we're going to talk about asthma, COPD, anaphylaxis, and really pulmonary edema. So in that, we'll be talking about the pathology of each disease state, the treatments of each disease state. And then I'm going to go, it's my thing, obviously I like medications. So we're going to talk a little bit in detail about some of the side effects and doses and things like that. So shortness of breath can have a huge differential, and I know that that's what you get the call for, right? People don't come into the ER complaining of, I'm having a CHF exacerbation. Well, sometimes they do, but a lot of times it's, I'm short of breath. And so in your mind, you have to kind of go through, well, could this be coronary artery disease? Do they have COPD? CHF, could it be a PE, foreign body obstruction even? Certainly pneumonia, asthma, and pneumothorax are other things, but just length of time is not going to allow us to talk about it. Plus, I get way too bored too quick. My attention span is not that. So just as far as breathing assessment goes, some of the big things that we all know, noisy breathing is abnormal, right? You should never hear somebody breathe, it's quiet. Anytime you can see somebody breathe, that's abnormal. That's a bad sign right there. And anytime they're in a position of breathing, that's always, and that's you walk in a room and what do you see? You know, somebody pursing their lips, breathing noisily, that's always bad. But I'll tell you what is also bad, and I know you know this, the silent chest. So if they're not making noise, that's probably even worse. So just as far as some assessments with respiratory status, do you guys know what rails are? Rails? They sound like, people just describe it as rubbing your hair between your fingers. And that's fluid in the small airways. Bronchi is just a louder sounding, hoarse sound in the larger airways. Wheezing, I know we're all familiar with wheezing. And again, silence is bad. So if you guys hear wheezing, which disease state are you thinking of kind of off the bat? For sure, asthma, right. And how about rails? What are you thinking about if you hear that fine crackly? At CHF, for sure, COPD sometimes, yeah. Wheezing with COPD as well, but for sure, CHF, pulmonary edema. That didn't turn out so well. Okay, some of the signs of respiratory distress, if somebody is nasal flaring, if they're using all accessory muscles to breathe, if they're cyanotic or pale in appearance. And I think a lot of things we do just very naturally. We go in the room, you look at the patient, and you're like, oh, that doesn't look so good. So the first disease state we'll go through is going to be asthma, very common disease state. So I'm going to start with a case of a 19-year-old male with a history of asthma, calls EMS due to shortness of breath and wheezing. And over the past 3 days, he's been sucking on his inhaler because it's just not working anymore, and he feels like it's getting worse. So it's minimal response. So when EMS gets there, he's speaking in short sentences and using accessory muscles to breathe. Vital signs, and I'll just read this out loud, 130/80 with a pulse of 110, respiratory rate of 22, satting 94% on air, and he feels afebrile. When you go in and you look at him, you see a male with good coloration who is, however, kind of sitting upright, wheezing throughout all fields, and he's tachycardic. Your eyes drop to his lower extremities, and you don't see any lower extremity edema. So it's an extremely common disease. Usually presents in childhood. A lot of times the kids have a history of eczema or hay fever, so they're kind of atopic patients. And it's a chronic inflammatory disease state of the lungs, which is associated with airway hyperresponsiveness. The big thing about asthma is that it's fully reversible. So the airway narrowing in asthma is fully reversible. So if you give them a beta agonist or other treatment, it should go back to the baseline of what it was. But if they do have some sort of a trigger, albeit a virus or an environmental, like some sort of environmental stimulus, they can get airway inflammation and lots of edema, lots of mucus production. And what happens is you get a narrowing of the airways. And the more edematous the airways get, the harder it is to treat. So this is just kind of, I think, a good example. So you're trying to give these asthmatics albuterol, and look what's happening. Do you think the albuterol is getting to where it needs to be? For sure not, right? So the more severe the exacerbation, the harder it is to treat. So when you have an exacerbation, they're going to be wheezing, they might be tachycardic, short of breath, using accessory muscles. They could be, if they're having a pretty severe attack, you'll see nasal flaring, maybe cyanosis. They're going to be kind of sitting in that tripod position that we've all seen. They can even be altered. So as far as treatment goes, we want to reverse the airway obstruction rapidly by aggressive use of beta agonists. And also early use of corticosteroids is key. You're going to give supplemental oxygen if needed. And in very mild cases, hopefully they may only need albuterol only, but if it's a moderate to severe exacerbation, you're going to establish an IV, high flow, depending on what they need via non-rebreather or CPAP, albuterol and ipratropium or Atrovent. Now, do you guys know why would we, if you have to give another treatment, what would the second drug be? What do you give following the Duaneb? Do you guys know why? Well, albuterol, Atrovent actually has a pretty long half-life, so you can only really give it every 6 hours anyway. So if you're going to give additional treatment, you can give albuterol. And it's just because of the half-life of ipratropium. So I'm going to just stop for a sec. Is this about what you all anticipated? Is there anything we should go back over? You're feeling good about this? Okay, all right, you're feeling good. I'm feeling good. Yes. Right. Oh, no, no cure, but it's just reversible at the time being. So after the attack, she was asking if there's actually a cure. There is no, unfortunately, there's no real cure, but at baseline, they should return back to baseline in contrast to COPD, where they don't return back, they don't have that response to albuterol. Eventually. Oh, I see what you mean. Is it a progressive disease? Is that what you're asking? No, it's not necessarily a progressive disease. And in fact, asthma is a little strange in that sometimes people can actually get better as they get older. So yeah, there's different triggers, there's different mechanisms. I'm not that familiar with it, but yeah. Okay, so if they do have moderate to severe asthma exacerbation, you're going to give them dexamethasone, any corticosteroid. But I think the one that people mostly carry in the field is dexamethasone, yeah? Okay. Now, if time permits and they're really having a pretty bad exacerbation, you can go ahead and give them magnesium 2 grams. It's 1 to 2 grams in 50 to 100 over 10 to 20 minutes. That does require a consult. So magnesium is kind of interesting. We're going to talk about it in a minute. But it can cause a small but significant amount of improvement in their breathing. Very small, but if you're on the verge of possibly intubating an asthmatic, then if that small amount is going to stave off intubation, it's probably worthwhile. So if you have somebody that's having a mild exacerbation, you know, big deal if you get an improvement of 15%, you know, their peak flow or the amount that you can blow out in a period of time goes from 350 to 400 or 350 to 365. It doesn't make any clinical significance. You'll consider CPAP if they're deteriorating. And in the worst case scenario, you're going to give epinephrine in the lateral 5.3 milligrams. And again, it's just, you have so much mucus and edema in those airways that no matter how much albuterol you give to them, it's not going to reach the place that it needs to go. So for our fellow, he was given nebulized ipratropium and albuterol. EMS established the line. They gave him dexamethasone, 10 milligrams, and he was transported to the hospital. In the ER, they put him on BiPAP with continuous nebs. They gave him MAG. It was a very short transport time. Otherwise, EMS would have done it. And he was admitted to the IMC for frequent neb treatments and BiPAP usage. Chest X-ray was done. So albuterol, it's a sympathomimetic amine. Specifically, it works on the beta agonists. If you remember, beta 1 is the heart, beta 2 is the lungs because there's 2 lungs. So it's a beta 2 agonist. And it does cause bronchial smooth muscle relaxation. So an adverse effect of albuterol is that it causes hypokalemia. So that lends itself to treatment of another disease, right? We could give it for hyperkalemia, tremulousness, tachycardia, very rarely lactic acidosis. So, and I had mentioned that IM epinephrine is only used for severe exacerbations when you're just limited by the amount that you can give of albuterol. So the real important thing, glucocorticoids. Overall, they can decrease mucus production, improve oxygenation, and actually decrease the amount of albuterol you need. The only problem with the steroids, do you guys know the problem with steroids? For sure you give them, right? Exactly. It takes 4 to 6 hours to work. So yeah, of course you're going to give it as soon as you can, but you're going to have to wait out that period of time until they start to work.
There's a question online, why would we use epi sooner? Why do we wait for moderate to severe disease?
And the answer would be that as long as you're getting the appropriate amount of delivery of albuterol to the patient's airways where it's needed, and that would be based on how they're responding. So if a patient, you're giving them the continuous nebs, and despite that, you're treating them, you're giving them the MAG, you've got the line established, you've given them dexamethasone, you know, you're, 20 minutes from the hospital, and they're still declining, then you for sure would give epinephrine. There's no question. But it's more of I think it's more of a severe exacerbation. So magnesium, we'll talk 1 minute about it. It can relax smooth muscles. It actually competes with calcium at the calcium binding sites. And I had mentioned already that you only see the efficacy of asthma exacerbations. So adverse reactions, I don't know if you've ever had people with pre-eclampsia or eclampsia that receive it, but they just get warm and flushed, and boy, do they feel terrible. It just makes you feel terrible. It causes hypotension, vasodilation, CNS depression, and in very high doses, you get hyporeflexia and definitely nausea and vomiting. So you just don't want to give it too fast because it can bottom their blood pressure out. My slide says you can't fix stupid, but you can intubate and sedate it. I had to throw in a few Gomer blog things in there.
Can I ask another question about asthma? So your thoughts about somebody with more of a silent, so not.
Yeah, and if they are in extremis and they're pale and they're kind of mottled in appearance and they're not speaking at all, then yeah, I think it's very reasonable to reach for IM epi. Very. Yeah, you would never be faulted for that. No, so that would, to me, if they're just retracting, that would be a mild to moderate case, a moderate case, I should say. And then I don't think it's indicated unless they're deteriorating and you're worried that you're going to have to intubate that patient. Because that's really, intubation in an asthmatic it's really very nerve-wracking. They can crump, you can get pneumothoraces. For me, it's a very scary patient. So yeah, it's always a very nerve-wracking experience. And I try to not intubate them if I can avoid it at all costs. And by all costs, I mean epi. Okay, so moving on to any other questions about asthma before we move on? Okay, all right, anaphylaxis. So I do want to stop and say one other thing too, not necessarily for anaphylaxis, but I'm presenting these as if they're each their own disease entity and will never be together in the same patient. You can absolutely have an asthmatic with COPD and a patient with COPD and CHF. So a lot of times it's a very overlapping picture. But just for clarity's sake, we're just trying to do one at a time. So anaphylaxis, my case is a 40-year-old female who has a history of hypertension, and she's on metoprolol, which will play a key role in our case. She called EMS. She actually had something to drink, like a celery juice, and then went to exercise after that. It feels like she's in really good shape, but then noticed her throat was tightening. Upon EMS arrival, they noted her blood pressure to be low, very tachycardic, not looking so well, O2 sats normal, and satting 99% on room air. En route, she actually breaks out in a rash. So they gave her 50 milligrams of diphenhydramine, and she got dexamethasone 10. I think I mentioned her, she was sinus tach. So now you have this diffuse pruritic rash with expiratory wheezing and mucosal and uvular swelling. So do you guys know what's given next? You've given her some Benadryl, right? And Dex. So what's your next go-to agent? Yeah, for sure. Epinephrine, for sure. Okay, so anaphylaxis is an acute, potentially fatal, multi-organ system reaction caused by the release of chemical mediators from mast cells and basophils, and it occurs after re-exposure to specific antigens. So anaphylaxis actually has a pretty interesting definition, and it's the presence of either skin symptoms together with either respiratory involvement or if you have two organ system involvement. So in other words, if I have somebody that has a diffuse itchy rash and they vomit, that's a GI symptom, and they now have a definition of anaphylaxis. So it's two organ system involvement. Or if they become hypotensive after eating something that is a known antigen. So in other words, if I have a peanut allergy and I accidentally eat something with peanuts, and all of a sudden I'm hypotensive, that's also defined as anaphylaxis. So it's signs or symptoms, two organ system involvement. And in 80 to 90% of the case, one of the systems is going to be skin or mucous membranes. So a majority of patients have some combination of urticaria, erythema, itching, rash, angioedema. Children very frequently get respiratory symptoms, followed by the cutaneous. And obviously, there's a small percentage of patients who don't have skin findings. So the first priority is airway, breathing, circulation, and adequacy of mentation. I think that's something that we all do reflexively when you just look at a patient, and it's a medical emergency. So some of the symptoms they can, I think I touched this. They can have throat tightness, wheezing, shortness of breath, hoarseness. Cardiovascularly, they can have dizziness, weakness, fainting, chest tightness. And again, I had mentioned that the GI system, they can have nausea, vomiting, diarrhea, even cramps. And some signs that when you're looking at the patient, you might see angioedema or swelling of the tongue, the lips. They can have stridor, hoarseness, wheezing. They can be hypotensive and tachycardic. And the classic skin manifestation is urticaria and angioedema. And so this is just one of the classic urticarial rashes, and this little kid has swelling of the face. So pre-hospital care is going to be airway management if needed, high flow oxygen, putting them on monitor and pulse ox, IV access, fluid resuscitation if they're hypotensive. And the primary drug treatment for acute anaphylaxis is epinephrine, diphenhydramine for your antihistamine, and H2 blockers like cimetidine or ranitidine or famotidine. I'm going to just take one step back and say about these agents, it's actually kind of interesting. The H2 blockers really just take care of the skin manifestations. So we give it, and we always give it, but it doesn't do a lot for the other system involvement. It really makes their skin look a lot better for what that's worth. So epinephrine is a sympathomimetic catecholamine, acts on both alpha and beta. It's actually one of the most potent alpha receptor activators that we have, which is exactly what we want because we get vasoconstriction, we decrease the vascular permeability. So if they have hypotension from this because of capillary leak, that will tighten up all your blood vessels. It also induces relaxation of the bronchial smooth muscle by acting on the beta receptors. Blah, 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 there's a lot of side effects. All right, you know what? I'm not even going to go over it because you know why? You're going to give it. It doesn't matter that there's a whole list of side effects. It doesn't matter. There is no contraindication to administering epinephrine for a patient who has anaphylaxis. It's the drug of choice, it's potentially life-saving, and it's usually tolerated pretty well. And one thing that was taught to us with epinephrine is that more people die without it than with it. So it's very interesting. In legal cases, more people have died without because they weren't given epinephrine than they were. So you can give 0.5 in the thigh every 5 minutes for a total of 3 doses. And if they are continuing to get worse, despite that, if they're in extremis with hypotension and impending respiratory failure, you can always mix up a drip. This would be an exceptional call. So adjunct agents, you can give albuterol, you're going to give corticosteroids. Now, if you have a patient who is on a beta blocker, this can make them not respond to the agonists, the beta agonists, and the epinephrine as well as they should. So to circumvent that, we can give glucagon. So if you have somebody who's on a beta blocker and you know they're on metoprolol, they are not responding, you've given them epinephrine, you can circumvent that by giving them glucagon. So that will work at the receptors at a different site. And of course, you're going to use vasopressors if you have it. So the anaphylaxis case, she was actually experiencing a food-triggered allergy, which seems to be more common in the literature now. Because of the beta blocker, she was refractory to the epinephrine. So she had been given IV fluids, glucagon, and was admitted to the intensive care unit. So steroids, we had touched on this briefly, but they do require 4 to 6 hours to work. So of course you're going to give them, but you just have to support the patient through the acute event because it actually has to go into the cell to make a second protein, to make a second messenger, which takes a long time. And it almost doesn't matter whether you give it orally or IV because it has to get inside the cell and start synthesizing something else. So corticosteroids, it's kind of like an epinephrine. If you need it, you need it, and there's no getting around it. But it can cause a leukocytosis or an elevated white count. It can cause hyperglycemia of really second concern. It can precipitate acute psychosis. Again, it's just one of those things. If you need it, you need it. And long-term exposure has a lot of side effects. So you do want to be careful if somebody's on them. And this is not for the EMS world, but in real life, in other world. They can cause a lot of bone disorders, diabetes, myopathies, skin thinning, osteoporosis. Oops. Okay. So moving on to COPD, anybody have any questions, comments, anaphylaxis, anecdotes, cases?
How sensitive is epi to temperature?
Oh gosh, that's a great question. I don't know. I don't know the answer to that. Yeah.
How sensitive to epi to temperature?
Now, there was a lot of work done a number of years ago that looked at the degradation of medications in these huge storage containers. And it actually was, I think, probably less than what we thought it was, but I don't really have an answer for you. Yeah, at one point I really wanted to study that, the drug degradation, especially in a hot ambulance that's, sitting with a motor running.
Right, and a lot of kids that carry these pens
Yeah.
are not being kept in ideal circumstances. So
Right. Yeah.
it's effective when they are at 80 degrees ambient temperature versus
That would be a very interesting study. I'm on board for that if you ever want to do anything. All right, so the third of 4 disease states that we'll talk about. I think we're going to be done earlier, you guys. So, sorry? Not sorry? Sorry, not sorry. COPD. So COPD, EMS is called for a female with shortness of breath. She's a 57-year-old woman with a 2-pack per day for 20 years of smoking. She's been having increasing difficulty with breathing and a productive cough for the past week. She really couldn't speak so well when you got to her and was only sitting at 81% on room air. And on exam, not looking so well and had some end expiratory wheezing. So COPD, they've changed this definition over the past couple of years. It used to be a triad of emphysema, bronchitis, and asthma/COPD were all within the COPD realm, but they've now separated it out. So COPD is actually now it's a clinical diagnosis based on changes of shortness of breath, cough, and sputum production. And in contrast to asthma, even if you give somebody a bronchodilator, which will open up an asthmatic, it won't open up a COPDer. So, please, yeah.
So it says, you're talking about asthma, and it says, considering an epi drip for asthma, at what point after the initial epi would you consider an epi drip? Or what about IM epi, would you consider that, or consult, since it's not a standing order for EMS?
What I believe I saw in the protocols was 0.5 every 5 minutes IM for 3 doses. I feel pretty confident that that's what, you would be doing that for sure before you'd be going to an IV drip. And that would be an exceptional call. That would be an exceptionally long, yeah, they would be out in the country, not county. Yeah, you would.
So pretty high threshold.
Very high threshold, correct.
Very unlikely.
Exquisitely unlikely, yeah. Okay, yeah.
As you said that asthma has been separated from COPD. Has emphysema is that still considered?
So emphysema, I think that they have defined that more pathologically. So what they actually have to, it has to do with the cellular level. Whereas before, I actually was surprised when I did this lecture because I always thought of them as all the same or in the same categories. But yeah, they had tweezed it out. Did I answer your question? Okay. So history can include dyspnea, cough, purulent symptoms. A lot of times COPD exacerbations are triggered by viruses. Very common to happen. So on physical exam, they can have hyperinflation, so you sort of know a COPD when you see them, right? They sort of look kind of thin and have this barrel chest. They may have tachypnea, tachycardic. They may be pursed lip breathing. End stage, they can be pretty cachectic or very wasted looking. They can have accessory muscle use, so prolonged expiratory time, wheezing, nasal flaring, retractions. And of course, they can be hypoxic, like my case presentation, and hypercarbic. So pre-hospital care for COPD is going to include establishing IV access. You're going to give them a Duoneb or Combivent or whatever they're called, Albuterol and Ipratropium, Atrovent. We'll provide supplemental oxygen titrated to a low but fairly normal O2, 88 to 92%. If they continue to deteriorate, you can put them on CPAP. And it's just interesting, if there's time, you're going to get an EKG. About 20% of COPD exacerbations can be precipitated either by heart failure, like we had mentioned, 2 disease states can go concomitantly, or they could have an arrhythmia. So a lot of these patients have atrial fibrillation. A new ventilator attachment safely allows smoking while receiving oxygen. Clearly it's Okay, so talking about ipratropium, It actually blocks acetylcholine at the cholinergic receptor. This causes bronchial muscle, smooth muscle dilation. It's actually interesting. It works more in the large airways than it does in the small airways. So asthmatics are less responsive to ipratropium than COPDs are. And ipratropium also works by decreasing secretions. It can be synergistic with albuterol. Kids actually have more cholinergic receptors than adults. So ipratropium works particularly well for children. Adverse effects are pretty nominal. Again, you're not necessarily going to be considering them when giving them. It can cause urinary retention, tremulousness, dry mouth. And if they actually have glaucoma and they're getting mist into their eyes, that can actually precipitate a glaucoma. And my last and final slide. Oxygen is less functional when the cannula is worn as a headband. On the arm? Yeah. I believe that would require therapy, like treatment, so either medication or otherwise. So, yeah, it's just something to be aware of. I don't know that I would necessarily change my practice unless somebody said to me, hey, I have glaucoma. I can't have that stuff on my face, But for the acute exacerbation, you're probably still going to reach for ipratropium. So COPD patients are also going to receive dexamethasone, either IV or PO. You can consider trying to use some magnesium if there's any reversible element. Bronchodilators, we had mentioned already that ipratropium has a long half-life, so you're only going to give it the one time. Corticosteroids, they do enhance the bronchodilator response, reduce the need for admission for COPD players, and also reduce treatment failures. So there's some decent evidence for use of steroids in COPD.
Is that long-term steroids?
Oh, no, acute. Yeah, this is the acute event, correct. Antibiotics, I think we probably all give them, although the data supporting antibiotic use is varied. It's not that great. For sure, if they're going to the intensive care unit, they get antibiotics. They do reduce treatment failures and in-hospital mortality. Non-invasive positive pressure ventilation, or CPAP. It's the mainstay for very severe exacerbations. And just to talk 1 minute about CPAP or BiPAP, if somebody has, just like any medication, oxygen has side effects, these devices have side effects. You definitely can't use them when the patient is either vomiting. Of course, if they're not breathing, that's not going to be very effective. Or if they have depressed mentation. So if somebody's starting to kind of go down, it's unfortunate you can't use CPAP. So the COPD case was started on Duonex, IV access was obtained, she was placed on CPAP, and in the ER they gave her methylpred, levofloxacin, and she was admitted to the IMC. My gosh, I really am zipping, yes.
Yeah, so can you talk to us a little bit about kind of the balance of oxygen therapy with COPD versus the patient needing a protocol to never get more oxygen?
Oh, yeah, I think that's absolutely true. And you can always titrate it down. When you walk into a situation, it's hard to know what you're walking into. So it's very reasonable to start off with high flow. For sure, it's very reasonable. And nobody would ever fault you for it. But if you start to gather more information and you realize, oh, this is a COPD patient, and she's probably always hypercarbic. It's not unreasonable to titrate the oxygen down. I think if there's any fault cited, that's erroneous. I almost always start with high flow oxygen and titrate it downward. So I was not trying to mislead you into thinking that, we're running around with applying 2 liters of nasal cannula to my very sick patients. We're not.
Idea that the isolation from lifestyle, because the lifestyle give oxygen to a COPD patient, that it's going to decrease the respiratory.
Yeah, I don't think I've ever seen that. Yeah, right. I don't think I've ever seen that. Any experience with, now what do you guys usually do? High flow?
Well, I definitely see limitation. Providers limit oxygen.
Yeah,
Because of COPD.
correct, yeah.
Right? So they don't want to suppress the respiratory drive.
Yeah. And it's probably more from the ongoing process, the COPD exacerbation, than it is from you giving them oxygen. Okay,
It's interesting that when you read that the CPAP is used widely in respiratory distress in the pre-hospital setting, you don't have a lot of communities, right?
right.
And in the hospital setting, there's actually very limited use, right?
Oh, yeah.
Non-invasive ventilation. It's only shown to be effective in only like 2 conditions, right?
Right.
One that you just covered, and the one that's coming up.
Yeah.
Other than that, it doesn't delay intubation at all. And it could even increase mortality. Right?
That I'm not aware of. CPAP? Interesting.
CPAP is a non-patient population because it delays providers from moving towards intubation.
Got it. So we're in the ER when we have somebody on BiPAP, where the trial period is really only 30 minutes, and you're supposed to make a decision at that point. Not that your transport time will ever be that, but if they are not getting better, doing worse at the 30-minute mark, that's when you're going for an endotracheal intubation. Okay, and my final, yes.
I got one quick question. It's not
Yeah.
really a question, but can you give a scenario for our BLS providers? I know we're talking at an ALS level, but we have a lot of BLS providers that are questioning at what point, because they can't use CPAP. At what point am I presented with these patients before ALS arrives where I should probably start bagging the patients, where I should, because they're going to go right from high flow oxygen and they're kind of limited.
Yeah.
And that's a lot of frustration for some of them when they get there before ALS arrives.
Yeah, I can imagine. Sure. So for the BLS community, are you specifically talking about
CHF, or COPD, I'm sorry.
COPD, or really, or any of them? Yeah. I'm not sure how to answer. I guess if they are, it depends on how long they're going to be there, what the ALS response time is, and how long is the pre-hospital transport. If you have somebody in front of you that is cyanotic, really looking fairly ill, maybe not speaking, and using any of the accessory muscles or very quiet, I think that would be the time when you would be, as a BLS provider, reaching to bag them. That would be, you're limited in your options, so.
You just treat the patient. What are you saying, treat it?
Yeah, I think that,
Well, that's,
BSL, I am a BSL.
yeah, but we have a lot of the younger providers, they're not,
It's the same thing with the high flow oxygen.
That's some of the things that we get
Look at
from-
what he's doing. I said, where's your sex?
right,
So are you
for
saying
sure.
BLS providers are hesitant to move?
no, that's not what I'm saying at all.
Can you repeat what
That
you're saying?
some of the younger BLS providers have expressed concerns. When do I go from high flow oxygen to bagging patients?
Yeah.
They don't have the options of drugs and medications and CPAP.
When they're getting tired, that's exactly, yeah, they're starting to,
really wears them out.
yeah, you're looking at them, their respiratory rate is 40, their tidal volumes, the rise and fall of their chest is very minimal. They're just looking ill. Maybe their mentation is, they're starting to go down a little bit. That's when you really, you're,
I think too, at that point, they're going to fight you to bag.
Oh,
They're
not at
fighting
all.
you to bag them, then you
Correct.
guys are going to it too soon.
Yeah.
If they're not fighting you and they're in that much distress, it's
Right.
probably the right time to bag.
And their blood pressure is probably on the downward trend as well at that point. So you know that their blood pressure is starting to become more soft and you're getting more concerned about their vitals. So yeah, that's definitely, everything would be going down. You start to think about bagging them.
It's very hard to bag an agitated person in respiratory distress.
Yes,
They have
exquisitely.
no interest in holding still and you bagging them, right? So that's probably not going to be effective.
Yeah, even for CPAP, if they're very agitated, sometimes it's so hard to convince them. Sometimes I have to convince them pharmacologically with Ativan to, a little sweet talk in there, yeah, to get them to just to wear the mask. So my fourth and final topic, and then we'll wrap it up, congestive heart failure. So heart failure is when the heart is actually unable to pump the blood during systole. So, the new term that people have been using over the past couple of years is HFrEF, or heart failure with reduced ejection fraction. So it typically starts off with some sort of injury to the heart, whether they've chronic high blood pressure or coronary ischemia, they've had some sort of a heart attack. And then the heart remodels or redesigns in the way that it impairs how it contracts. So it cannot contract as well. And it becomes thicker, and the heart is just unable to pump the blood forward. So a CHF case could be, we have a 63-year-old male who's struggling to breathe. The family is there and they say he has a history of heart failure and has been sleeping upright in his living room chair for a couple of days. When you get there, his blood pressure is exquisitely high, 200 over 130. Pulse of 100, he's satting 70% on the air. And again, in respiratory distress, sitting forward, coarse, wet breath sounds. So if you have a patient and you're thinking about what the difference, kind of very quickly, edema or CHF in patients with tachypnea, hypertension, I think is one of the big markers for me. So if they come in exquisitely hypertensive, they've got rales, hypoxic, and tachypnic, I'm really considering CHF, and they usually have a diagnosis. So they're on heart failure medicines, and they're on diuretics, and CHF, I think the diagnosis can be challenging at times. Like I said, if they have a history of CHF, it's definitely going to make you consider it much more highly. If they have JVD, if you can look at their neck. Now, I was convinced for years that this was a made-up thing because I could never see JVD. But if you look at their neck and it's exquisitely full, and they've got these coursing veins, you can almost feel confident that they have CHF. And then they'll have a history of atrial fibrillation very frequently. Orthopnea, or shortness of breath, with walking, dyspnea on exertion, orthopnea, or if they lay down at nighttime and the fluid redistributes into their lungs, that's paroxysmal nocturnal dyspnea. So they could have those symptoms. And as I mentioned, their blood pressure is frequently elevated. They'll have rales. You drop your eyes down and they've got these gigantic swollen legs. They can have JVD if you just glance at their neck. And then hypoxia. Now, I will mention that, so we're talking about left heart failure, and I have to memorize things in very simple ways. Left empties the lungs, so your left ventricle is what's emptying your lungs. So if your left ventricle is failing, that's what we call heart failure, and you get pulmonary congestion. The the left heart side of the heart frequently causes right heart failure, and then fluid backs up this way. So that's why you get these gigantor veins here and in your lower extremities. So it's right heart failure and left heart failure. Left is lungs, and that's when you get the pulmonary congestion. So these are both obviously right heart failure and left heart failure. You can have a patient who doesn't have right heart failure. You know, their legs are nice and slim and they've got no JVD. But if you listen to them, they're hypertensive and they've got RALs, well, then they have left heart failure. So stabilization, airway, and breathing, you're going to give them supplemental oxygen. I think here, in contrast to the others, we're going to be giving them some sublingual nitroglycerin. CPAP, as soon as you can if they're in extremis, and then 12 lead for ischemia. So the goal of CHF, you have, for whatever reason, your heart is unable to pump the fluid forward out of the lungs, okay? So either it's because your blood pressure has become markedly elevated and the heart just can't do it, or you have too much volume in you. Maybe your kidneys are failing and you just overall have too much fluid, and it's just too much fluid for the heart to pump out of the lungs. So your goal of therapy is you want to reduce the pressure of the blood going back to the heart. You want to essentially create a reservoir, so an extra space for that extra fluid to go. So you'll preload reduce them with nitroglycerin, and then you're going to try to afterload resist them, to afterload reduce them as well. So that will allow the heart to pump blood forward more easily. So nitroglycerin very nicely accomplishes this. So you have good preload reduction. For mild CHF, you can give 0.4. For moderate or severe, you can start with 0.8. Alternatively, 0.4 and then slap some paste on. Are there any questions with that? Do you feel like you understand? Yeah.
Does the hypertension arise just out of the chronic hypertension that got them to CHF to begin with, or is it an acute symptom of the exacerbation?
So both. The answer is both. You can have hypertension. I think I'm understanding you correctly. You can have hypertension, an acute hypertensive emergency that precipitates pulmonary edema, or because you're in extremis from your pulmonary edema, from your heart failure, you can be markedly hypertensive. Either way, the treatment's the same. You're going to preload and afterload reduce them with nitro. So the patient was placed on a non-rebreather, monitor, IV. He was given some sublingual and then started on CPAP. At the ER, he was placed on BiPAP, started on a high-dose nitroglycerin infusion, given some diuretics, and admitted to ICU. So what if you give these patients albuterol? You know, you got this guy who's wheezing, they may or may not have asthma, they're short of breath. Is that going to be a big deal for these patients? Not at all. Yeah, if you give albuterol, we've had studies that have shown that there's no harm with that. Now, that's kind of in contrast to diuretics. So hospitals now are doing this, or have been trying to do a door to diuretic time, but that only works if the patient has CHF and you know that they have CHF. So if you give diuretics to a COPDer, that can actually cause harm. But if you give albuterol, it's not going to harm the patient. So that's just an FYI. Again, these things are not often as clear-cut as we wish they were. So albuterol, if you give them that pre-hospital, no big deal. I don't even think you guys carry diuretics anyway, right? Diuretics, Lasix, not negative, right?
How would diuretics harm a COPD?
That's a good question. I'm not exactly sure. I don't know your answer. Yeah, but they have given it to undifferentiated respiratory distress patients, and more harm was caused than helped. So just to kind of summarize everything that we went over, I know we went over a lot of information. But asthma is characterized by airway edema. They get this mucus production and inflammation in their small airways. You treat them with steroids and nebs. Anaphylaxis, 2-organ system involvement, usually the skin. Epinephrine is your drug of choice. You're never going to hesitate with that. Steroids and antihistamine is second. COPD is characterized by dyspnea, cough, sputum production. You treat with nebs and steroids. And then finally, CHF is characterized by poor cardiac contractility causing pulmonary congestion. The left ventricle just can't empty the lungs. You're going to preload reduce them, afterload reduce them with both nitro and give them CPAP. So that's it. That's the end. Sure.
So question online, so how long does the patient have to be hypertensive and which pressure would cause it to show edema in the lungs? So how hypertensive do people have to be for this to become an issue?
How hypertensive? Pretty hypertensive. So I'm going 200s over 100s. And I typically, although I have no data to support this, absolutely, but I typically think of it as an acute rise in blood pressure in which your heart cannot keep up with the immense pressure that's forced upon it. So your ventricle just can't unload. So I would think of that as a hypertensive emergency where you get a crisis, your blood pressure shoots way up. Normally you're normotensive, and for whatever reason you're very hypertensive. Then you can be thrown into pulmonary edema. The chronic long-term hypertensive patients usually fare fairly well, but it's that acute rise that really can harm you. Yeah.
Field question. Suppose you have a patient who's on an LVAD.
Oh, Lord, please.
Patients on LVAD.
The question started off with LVAD.
I'm curious if you have a patient who's got a history of congestive heart failure, they progress and now they're put in a assist device. Does your treatment plan change? Do you modify CPAP, no CPAP, nitro, no nitro? What happens to them?
That is a fantastic question, and they give me absolute chest pain, those LVAD patients. I've treated one in my life, so I really don't know. I've been doing this for 10, 11 years now.
What was the question about the LVAD?
If they have, do you treat them any differently? And the honest answer is, I just have no experience.
They're congestive heart failure, they are treated eventually with an LVAD device. Now they're complaining of shortness of breath. Does your treatment modality change?
Everything's going to change once the LVAD's been implanted.
To the extent of what?
Well, it depends on what degree of control the heart's going to have or no longer has with the LVAD in place. So most of the time you can control a lot just by how much you make your cardiac output.
So is there still a role for CPAP or for nitro in a patient on an LVAD?
Think of it in the
CPAP
field.
is going to be more for an acute problem. And everybody, remember, a lot of times they end on for multifactorial. It's not just coronary disease. They could also have pulmonary disease. But generally, you're not going to be doing that. And basically, for LVADs, to get into the LVAD center, we'll interrogate it, see what it's flowing, and get a bigger picture. So a lot of times, they might need to be diuresed. They go into fluid diure.
What would you agree that until the LVAD settings can be changed, which isn't by us, the same as we're hauling to the LVAD center.
Yes.
Sure, but in the meantime,
Right.
Of course we would give nitro, of course.
Yeah, I think,
Of course we would see.
right, I think oxygen, I think that would all be fair game. You're going to have to support them. But yeah, they don't, I'm just, that they don't go to Bayview. They are bypassed to another facility and not me, because they're just terrifying.
You want to get an LVAD patient to the LVAD center.
Correct.
Generally, they're not knowing it.
They'll tell you.
Yeah.
And there's a great LVAD talk, right? So that we had an LVAD speaker, we had a coordinator, and an LVAD patient here that's recorded on the YouTube site on PDFD.
Well, I know where I have to go now. For sure. All right, well, thank you guys.
Thank you.